Hello, everybody. My name is Darren Birch, and I am the Physician Outreach Liaison for Legacy. So today, I have a great privilege of working with and now introducing Dr. Reddy. He is the Medical Director of our Heart Failure Cardiology program here at Legacy Health. And our heart failure clinic, we have two heart failure clinics that he runs, one here at Legacy Emmanuel Medical Center and the other at Mount Hood Medical Center. So we're actually quickly building this team, and we will have additional access and additional services for heart failure patients for you, all the community providers. So thank you very much for joining today. Again, this is part one of a 4-part series. So our next talk is next month, March 18th, that you'll be able to join. So I'll just turn it over to Dr. Reddy, and we'll go from here.
Hi, everybody. This is Raghuram Reddy. I thank you, Darren, for the introduction. As Darren mentioned, we started our heart failure clinic here about a year ago. So it has myself as the attending and the director, and we have a nurse practitioner who will be starting on 1st of March, full-time nurse practitioner. We have a full-time heart failure RN, Susan Bladen. She has been here with us close to a year now. We have a full-time MA, Charles Griffith, and we have a full-time clinic social worker. And we are here Monday to Friday from 9 in the morning until 5 in the evening. And our team goes to Mount Hood Medical Center once a month. It is a second Tuesday. Usually it's the second Tuesday of the month. So feel free to contact us. And the best phone number to call us is 503-413-4187. 503-413-4187. That's the direct heart failure line, and it gets to Susan Bladen, and she will return your call within 2 business days. And if it is an urgent question, you can always email me on my Legacy email, and I will get back to you as soon as possible within less than a day. Okay. So the learning objectives for today are when and why to prescribe ARNI, and when and why to prescribe SGLT2 inhibitors, and to summarize the use of ARNI SGLT2 inhibitors in the management of systolic heart failure based on current guidelines. I have no disclosures for this presentation, and Legacy Health is accredited by the Accreditation Council for continuing education. So beginning with what is an ARNI? So sacubitril valsartan is the only available ARNI currently, and it has 2 components. The first component is sacubitril, which is a neprilysin inhibitor. And the second component is valsartan, which is an angiotensin receptor inhibitor. Can I get rid of this slide?
Yep.
So how does, what's the mechanism of action of ARNI? So this is a picture from Cleveland Clinic Journal from 2015, as you see the reference there. So there are 3 parts to this picture. The first part is the renin-angiotensin system. The second part is, how do I get it? The natriuretic peptide system, and then the bradykinin system. So as we all know, angiotensin is released from the liver, and it then gets converted by the renin that is produced by the kidneys to angiotensin 1, and then angiotensin 1 gets converted to angiotensin 2 by ACE, angiotensin converting enzyme, and then the angiotensin 2 is the final product, which then binds to the AT1 receptors on the cells and produces the action. So when it does bind to these receptors, it results in a bunch of actions. So what does valsartan do? Valsartan blocks the binding of angiotensin 2 to the AT1 receptor, and by doing so, it lowers the blood pressure, thereby decreases the afterload. It decreases the sympathetic tone. It decreases the aldosterone levels, and it also decreases cardiac fibrosis and hypertrophy. The sacubitril part, what does that do? So the natural course in the body is pro-BNP is produced in the body, gets converted to BNP, and BNP then interacts with the receptors on the cell, target cells, and it causes its effects. So neprilysin is an enzyme which degrades BNP and limits the actions of the BNP. So what sacubitril does is it inhibits the enzyme and increases the levels of BNP so that we could get the effects of BNP, which include lowering of blood pressure, lowering sympathetic tone, decreasing aldosterone levels, and decreasing cardiac fibrosis, hypertrophy, and increases natriuresis. All these help in patients with systolic heart failure. There is one other thing that sacubitril does is it also inhibits the conversion of bradykinin to inactive fragments, thereby increasing the levels of bradykinin in the body. And these then lower the blood pressure, and that equates to decreasing afterload in patients with heart failure, increase in nitric oxide for better performance of vascular endothelium, and also it causes natriuresis. So that is how sacubitril valsartan works. You get the effects of 2-for-1, neprilysin inhibitor and valsartan. So what are the current indications of ARNI? ARNI has a class 1 indication for treatment of stage C heart failure with reduced EF in the outpatient setting. ARNI can be safely initiated in patients with heart failure with reduced EF who are hospitalized for acute decompensated heart failure. ARNI is currently being reviewed for use in heart failure with preserved EF. We'll be talking more about that in our third lecture. So what's the evidence for ARNI? So heart failure with reduced EF as an outpatient indication. Paradigm HF, this study was published in NEJM 9/11/2014. Then heart failure with reduced EF for inpatient initiation. Pioneer HF, NEJM 27/2019, 2 years ago. Heart failure with preserved EF as an outpatient indication. Paragon HF, NEJM 10/24/2019. And then sacubitril valsartan and reverse cardiac remodeling. There are some data that there is probably reverse cardiac modeling with the use of sacubitril valsartan. And the trial that looked into this is Proof HF JAMA from September 2nd, 2019. So those are all the available major clinical trials relating to the use of ARNI predominantly in heart failure with reduced EF, and there is one trial in the preserved EF. So let's look into each one of these. So ARNI and heart failure with reduced EF in the outpatient setting. So stage C heart failure with reduced EF. It was first approved July 7, 2015. Then in 2016 and 2017, ACC, AHA, HFSA, there were focused update, and they gave it an indication of class 1 BR. BR meaning based on one clinical trial, which is Paradigm. So this is the flow diagram from 2017 ACC Expert Consensus Decision Pathway for Optimization for Heart Failure Treatment. So as you can see on the top, heart failure with reduced EF, stage C. And if you can see, here it says ACE or ARB and beta blockers as the first line therapy. ACE or ARB and beta blockers plus diuretics as needed as the first line therapy. And then if you follow this arrow here, for patients with who are stable on ACE or ARB, NYHA class 2 or 3, if they're still symptomatic, then switch to ARNI. So that was in 2017, which is 3 years ago. Fast forward to 2021, update to 2017 ACC Expert Consensus Decision Pathway. This is basically an update to the one in 2017. And you will see the difference here. Heart failure with reduced EF, stage C treatment. This just came out in February. Here you will see ARNI/ACE/ARB, and ARNI is preferred. So that's the difference. In 2017, it was ACE and ARB, and then switched later on to ARNI. Now it is ARNI, ACE, or ARB, but ARNI is preferred to ACE or ARB. So let's get to the main trial that tested sacubitril valsartan versus enalapril. Like I said, this trial was published in NEJM 9/11/2014. It was a randomized, double-blind, multi-center, active and control arm clinical trial. So the trial compared the efficacy and safety of LCZ696, which is nothing but sacubitril and valsartan, and enalapril in patients with heart failure with reduced EF or chronic systolic heart failure. So the active arm was the LCZ696, which is sacubitril valsartan, and the control arm was enalapril. So a total of 4,187 patients were in the LCZ696 group, and 4,212 were in the enalapril group. And the median follow-up was 27 months. And I have the full reference at the bottom of the screen if people want to get the details. So what are the inclusion criteria? 18 or above, LVEF equal to or less than 40%. That's the definition of heart failure with reduced EF, but this was later changed to 35%. And the BNP equal to or greater than 150, and NT-proBNP equal to or greater than 600. Heart failure hospitalization less than 12 months with a BNP of equal to or greater than 100, or with an NT-proBNP of equal to or greater than 400. And for 4 weeks prior to screening, they should have been on a stable dose of beta blocker and an ACE or an ARB equivalent to enalapril 10 milligrams daily. What are the exclusion criteria? Systolic blood pressure at screening less than 100, and at randomization 95, and GFR at screening less than 30 milliliters per minute, or a drop in eGFR by greater than 25%, and that was changed to 35% between screening and randomization. So for example, if people had a GFR of 40 or 45 ml per minute at screening, and then their GFR dropped by more than 35%, at randomization, they were excluded. So sacubitril valsartan people were excluded with GFRs less than 30 milliliters per minute, which is stage 4 kidney disease. So that is something we need to remember. And if the potassium was 5.2 at screening, or if it went to beyond 5.4 at randomization. And people who had either angioedema or unacceptable side effects to ACE or ARB. There are a lot more exclusion criteria than I presented here. So if people want to get all the details, they can go to the reference I put at the bottom of the screen and get those details. I just chose the ones that are very clinically relevant to our day-to-day use of ARNI. So this is the slide that talks about the endpoints and results. So the primary endpoint was a composite of death from cardiovascular disease or first hospitalization for worsening heart failure. So it was either or. And the secondary outcomes were death from any cause, which is all-cause mortality, then quality of life, new onset atrial fibrillation, and decline in renal function. Okay.
So there's a question, do we need to start ACE or ARB prior to prescribing an estro, or can we start it as first line?
So based on 2021 decision pathway, which just came out 2 days ago, ARNI is the first line. So you don't have to. Based on 2017 decision pathway, you have to start ACE or ARB first, and if they are still symptomatic, then switch it to ARNI. But that has changed. Now ARNI is first line.
Okay.
So like we said, we were talking about the primary composite outcome, death from cardiovascular cause or first hospitalization for worsening heart failure. And the secondary outcomes were all-cause mortality, quality of life, new onset atrial fibrillation, or decline in renal function. So we'll go to the next picture. So going back here, I would like your attention on the hazards ratio for the primary outcome, which is 0.80, and the confidence interval 0.73 to 0.87. And the p-value for that is very significant, less than 0.01. So this tells me that LCZ 696, or the sacubitril valsartan, was better than enalapril in preventing death from cardiovascular cause or first hospitalization for worsening heart failure. And by how much? The risk reduction was by about 20%. And this then translates into these numbers here. It's a little difficult to understand the risk reductions, but it's fairly easy to understand the number needed to treat. So if you look at the primary endpoint, which is death from cardiovascular cause or first hospitalization for worsening heart failure. So the number needed to treat is 21. What does that mean? So it means you need to treat 21 patients with heart failure with reduced EF, less than or equal to 40%, NYHA class 2 to 4, along with guideline-directed therapy for a period of 27 months to save one life from dying from cardiovascular diseases or first hospitalization. So that is a wonderful number. And then they split this down into the components of death from cardiovascular causes. The number needed to treat is 33. It's still significant. And first hospitalization for worsening heart failure, it's still relevant. So they went on to look at the secondary endpoints, which is death from any cause, and the number needed to treat is 35. So these are really clinically relevant and significant numbers, making sacubitril valsartan a better treatment compared to enalapril. And this is the slide which talks about, looks at the adverse events during randomized, during the trial period. So the adverse events include hypotension and worsening renal failure, hyperkalemia, cough, angioedema. Those are the main ones. So the only one that turned out to have some statistical significance was hypotension. So as you can see here, this is the LCZ 696. or sacubitril valsartan arm, and this is the enalapril group. So in the LCZ 696, there were about 17% of patients who had hypotension. In the enalapril group, there were about 11%, and that was statistically significant. Other than that, and then if you split the serum creatinine down to greater than 2.5 and greater than 3, in fact, people in enalapril group had more renal insufficiency than the sacubitril group. And with regard to angioedema, there were 19 patients in the LCZ 696 group and 10 patients in the enalapril group, and that was not statistically significant. So the take-home point for me here is it's the hypotension which occurs more frequently in the sacubitril valsartan group as opposed to enalapril group. So what are the big takeaways from Paradigm HF? So treatment with LCZ 696, which is sacubitril valsartan compared to enalapril, resulted in the following statistically significant outcomes: reduction in cardiovascular death, reduction in heart failure hospitalization, reduction in death from any cause, improvement in quality of life. And what was the downside? The treatment with LCZ 696, sacubitril valsartan compared to enalapril, resulted in statistically significant symptomatic hypotension, 17% in the sacubitril valsartan group and 11% in the enalapril group. However, this is per authors. This rarely required discontinuation of therapy. So you can work around it. And we'll talk about what do you do when you administer sacubitril valsartan and they get hypotensive. How do you deal with this? We'll come to that. So now let's turn our attention to how do we initiate ARNI in patients who are admitted to the hospital for acute decompensated heart failure. So Pioneer HF told us that sacubitril valsartan can be safely initiated in patients who are admitted for acute decompensated heart failure. So that's the trial Pioneer HF, published in NEJM 27/2019. And once again, this is a multi-center, double-blind, randomized controlled trial. The objective of this trial was to assess the safety and efficacy of initiation. I repeat this again. The objective was to assess the safety and efficacy of initiation of sacubitril valsartan in patients with heart failure with reduced EF admitted for acute decompensation. This is not an outcome study. This is a safety and study predominantly. So there were 441 patients in the sacubitril valsartan group and 441 patients in the enalapril group. And they were followed for about 8 weeks. And the reference is at the bottom of the screen. So what were the inclusion criteria? 18 and above, acute decompensated heart failure, LVEF should be less than or equal to 40%, NT-proBNP equal to or greater than 1600, and BNP greater than equal to or greater than 400. And this is the key, the hemodynamic stability. Before you start patients on sacubitril valsartan, their systolic blood pressure should have been equal to or greater than 100 for the last 6 hours. And there should not have been any increase in the IV diuretic dose. So if they were getting 40 milligrams of IV Lasix, it should be 40 milligrams, not 60 milligrams in the last several hours. No IV vasodilators in the preceding 6 hours. Vasodilators meaning milrinone or IV nitroglycerin or IV nitroprusside or neseritide, whatever you're using. And no IV inotropes in the preceding 24 hours. Again, they should not be on IV dopamine, or milrinone in the last 24 hours. So they should have been hemodynamically stable before you initiate. And The enrolling period was less than 24 hours up to 10 days after presentation to the hospital, but they are still in-house. The exclusion criteria, again, there were multiple. I just chose the ones that are clinically relevant for us. If they were on an ARNI in less than 30 days as an outpatient, and hypersensitivity and intolerance to ACE or ARB or sacubitril, angioedema to ACE or ARB, EGFR less than 30 ml per minute, again, so stage 4 kidney disease and below or higher were not enrolled, and potassium greater than 5.2, so hyperkalemia. And if they were in the hospital for additional diagnosis of acute coronary syndrome, CVA, TIA, coronary or carotid revascularization. So any major cardiovascular revascularization, they were excluded. So what were the endpoints? So the primary endpoint was a change in the NT-proBNP from baseline. And the safety endpoints, this is what I think we are more interested in. Was there worsening of renal function? How did they define that? So has the creatinine gone up to 0.5 or greater from baseline, or if the GFR has gotten worse by 25% or greater? Was there symptomatic hypotension? Was there hypokalemia? Was there angioedema? So those were the 4 safety endpoints: worsening kidney function, symptomatic hypotension, hyperkalemia, angioedema. And there were multiple secondary and exploratory endpoints, which we are not going to discuss during this lecture. And what did they find? Yes, so the bottom line, the x-axis is the weeks in randomization. So it goes from 0 to 8 weeks. And the y-axis is change in the NT-proBNP. The top line, the black line is the control arm enalapril. And the bottom line, the red line, is the patients who got sacubitril valsartan. So as you can see, the proBNP does go down in both, but goes down significantly in patients who received sacubitril valsartan. And why is that important? So the higher the NT-proBNP or BNP, the higher is the neurohormonal activation, hemodynamic stress, and it correlates to outcomes. So that's why it's almost like a surrogate to all of these factors. And like I said, more than the, it's not an outcome study. It was mainly a safety study, whether we can safely start this medication in inpatients. So they looked at 4 of the outcomes. So the 4 key outcomes were worsening renal failure, hyperkalemia, hypotension, angioedema. And this is the sacubitril valsartan group, and this is the enalapril group. And as you can see, there is none of these 4. There was any statistically significant difference between both the groups. 13.6% here, 14.7%, not statistically significant, 11.6%, 9.3%, but still not statistically significant, 15%, 12.7%, not significant, the same thing here. So the way you find out whether it's statistically significant or not is if you see a 1 in the confidence interval here, it's not. So it goes from 0.67 to 1.28, so there is a 1. The same thing here, and the same thing here. So there was basically no difference in any of these key safety outcomes between the 2 groups. So based on this, so what are the takeaways from our Pioneer HF? Sacubitril valsartan can be safely initiated in patients with systolic heart failure with LVEF at or less than 40% and acute decompensation, provided they are hemodynamically stable. And I described those 4 characteristics which define hemodynamic stability. So you have to choose your patients. You have to choose your patients. You can't give it to anybody. You have to make sure that they are hemodynamically stable. They are off inotropes. They are off no escalating doses of diuretics. and their blood pressures are stable, their kidney function is stable, and then give it. So no statistically significant difference in worsening renal failure, hyperkalemia, symptomatic hypertension, or angioedema between both the groups. So the point is, you don't have to wait for these patients with heart failure, with systolic heart failure, admitted to the hospital for acute decompensation, for them to be released from the hospital, see them in the clinic, and initiate. So you can actually start those sacubitril valsartan while they are in-house, probably prior to discharge, something like that, and then follow them through the outpatient. So the last indication for ARNI, heart failure with preserved EF. So currently ARNI is not approved for use in patients with a preserved EF. It is under review. Stay tuned for more updates. I just heard from one of my, I shouldn't say, the industry people saying that it is now being approved, but I can't say that for certain until I do my homework. But for now, I think stay tuned for updates. And by the time we do our third lecture, probably we'll get those information. Then how do you prescribe sacubitril valsartan and uptitrate and follow up? So prescription and uptitration. So I'm going to tell you, if you're starting this de novo, so assuming that they are not on ACE or ARB or any afterload reducing agent, and you are choosing one. So based on 2021 decision pathway, you have to choose, or ARNI is preferred. So you start with 24-26 milligrams POBID. It comes in 3 strengths: 24-26, 49-51, and 97-103. So you start at 24-26 POBID, up titrate every 2 to 3 weeks based on their blood pressure, renal function, patient's tolerance, and to a maximum dose of 97-103. So you start 24-26, see them in the clinic in 2 to 3 weeks, check their blood pressure, renal function, how they're doing. If they're doing well, then go up to 49-51 BID for another 2 weeks or so. And then if it's doing well, up to 97-103. And switching from ACE to an ARNI. So if somebody is on an ACE or an ARB, and you want to switch them. So if you're switching them from ACE to ARNI, then you have to give them 36 hours of washout is essential. Because if you do not do that, the ACE with ARNI, the ARNI in the setting of ongoing use of ACE can result in angioedema. And for switching an ARB to an ARNI, no such washout is required. You can do a switch out right away. So when you do follow them in the clinic, these are the things you need to be paying attention to. Hypotension, so 17%. Trial data says 17%. So that is roughly 1 in 5 patients who receive ARNI develop hypotension. So what do you do? So usually people who are on ARNIs, their requirements for diuretic goes down. Remember the neprilysin inhibitor, which is sacubitril, it acts like a natural diuretic. So it decreases it causes diuresis, natriuresis, diuresis. And so you have to watch for the hypotension. And if they are getting hypotensive, the first thing I would do is decrease the diuretic or even stop the diuretic. And if they are on additional blood pressure medications like amlodipine or something else, you try to cut those down. And if you stop their diuretics, if you adjusted their blood pressure medications, if they are still on the hypotensive side, just slowly up titrate. Instead of up titrating every 2 to 3 weeks, go 4 to 6 weeks. Give ARNI the best benefit of doubt because the outcomes are so good. Then renal insufficiency and hyperkalemia. So I usually do a basic metabolic panel with GFR 1 week after starting ARNI, 1 week after starting ARNI. And I usually stop them if their creatinine rise is equal to or greater than 30% from baseline or from before, or potassium, if it goes to 5 point, that should actually say 5.4. 5.4. So close monitoring with BMP with GFR is essential. You just can't start the medication and forget for the next 2 weeks or 3 weeks. So you have to do a monitoring BMP a week later and see where we are. If the rise in creatinine is close to 20, 25%, you may want to repeat in the next 3 or 4 days to see where we are going.
So we have a question, Dr. Reddy. Any need to change the beta blocker dose even if the blood pressure is fine?
That's a great question. I do change. For example, if they are on carvedilol versus metoprolol succinate. So carvedilol is an alpha and beta blocker, while metoprolol succinate is a specific beta blocker. So with metoprolol succinate, you do not get much hypotension, but with carvedilol, which is an alpha blocker too, you get hypotension. So if people are on carvedilol and an ARNI, and you looked into the diuretic, you adjusted all things, and now they are on carvedilol, I switch them from carvedilol to metoprolol succinate to get that blood pressure. Great question. This is very, very practical question. And I see quite a few people saying hypotensive, I can't up titrate. So please look into all these issues. And the last thing is watch for angioedema. Though it is rare, watch for angioedema. So the 3 things I would say when you start a person on ARNI is hypotension, and work around the hypotension by looking into or adjusting or stopping the diuretics, adjusting blood pressure medications, slow up titration, switching from carvedilol to metoprolol succinate. And then renal insufficiency, hyperkalemia. Please make it a habit to check their BMP GFR1 after initiation, and based on that, and watch for angioedema. So that brings us to the end of ARNIs, and we now move on to SGLT2 inhibitors. And these are sodium glucose cotransporter 2 inhibitors. And this is how these group of medications act. So multiple proposed mechanisms, and I can read these out to you. So there are SGLT2 and heart failure, and SGLT2 and atherosclerosis, which is CAD, and SGLT2 and kidney disease. So there are multiple ways they act. The main ones are they cause osmotic diuresis and natriuresis, and thereby they decrease the blood volume, weight loss, and help reduce the blood pressure, weight. They also have direct cardiac effects, which I'll have a cartoon, I'll show it to you. Then they decrease the sympathetic nervous system overdrive, which is very essential, which is a key component in the pathogenesis of heart failure. They also possibly improve the efficiency of myocardium. They improve the oxygen delivery through stimulation of renal EPO, and they decrease oxidative stress. And lastly, they decrease hemoglobin A1C, reduce the blood pressure, reduce the body weight, and improve vascular stiffness. So there are multiple ways that these medications act. This is, I don't know how we are doing with time, but here, these are the renal effects of the SGLT2s. So this here is the normal renal tubule. This here is the abnormal, renal tubule with impaired physiology or abnormal physiology. And this is the renal tubule or nephron with use of SGLT2. So anything you see in red is bad, and anything you see yellow is good. So the SGLT2 receptors are present in the proximal convoluted tubule. And there is one other cotransporter, which is called sodium hydrogen exchange pump. But we are interested in SGLT2s at this time. So that's the afferent arteriole, which brings the blood into the glomerulus. And this is the efferent arteriole, which drains the blood from the glomerulus into the renal veins. So renal arteries, afferent arteriole, efferent arteriole, renal veins, and IVC. So that's how I remember. So blood gets filtered from the glomerulus into the proximal tubule, most of it is reabsorbed here, particularly sodium and glucose, and then goes through whatever is left, goes through the loop of Henle into the ascending limb and in the distal convoluted tubule. And this green structure is the juxtaglomerular apparatus or the macula densa, which senses what is happening in the renal tubule and affects the tone of the arteriole, afferent arteriole. So this is normal and in abnormal, for example, diabetes mellitus. So there is increased reabsorption of sodium and glucose through the proximal convoluted tubule. So there is less sodium delivered to the juxtaglomerular apparatus. So that senses the decreased sodium load, and it causes afferent arteriolar dilatation. And that afferent arteriolar dilatation causes renal glomerular hypertension, hyperfiltration. And that's how the renal adverse effects are caused. And that in turn reflects in cardiovascular effects. So what happens when you give SGLT2s? The SGLT2s, they block these co-transporter systems in the proximal convoluted tubule. They block them. So sodium and glucose is not absorbed. And now the tubular fluid has high sodium content. And that high sodium content, as you can see a lot of sodium signs here. And they stimulate the juxtaglomerular apparatus here. And that in turn produces the adenosine. And that adenosine results in afferent arteriolar constriction. And that is how they bring about their effects on heart and kidney. And this is a picture. This is specifically on the cardiac myocytes. And very quickly, this is cardiac myocyte in a patient with heart failure and diabetes mellitus. So you can see, as you can see, there are 3 pumps here. The popular sodium potassium ATPase pump, everybody knows. It pumps out 3 sodium ions for every 2 potassium ions. It's an energy dependent system, and it derives its ATP from the mitochondria. So, and this is the sodium hydrogen exchange pump. And in patients with heart failure and diabetes, there is increased sodium and calcium in the cytoplasm and decreased calcium and ATP in the mitochondria. This is a bad situation. So what do SGLT2s do, or the proposed mechanism? They block the sodium hydrogen exchange pump. And by doing so, the intracytoplasmic sodium and intracytoplasmic calcium are lowered, and the intramitochondrial calcium is higher, and that results in high ATP production, and that ATP is used for sodium ATPase pump, and that improves cardiac function efficiency. So that's how they work at heart level, and that's how they work at the kidney level. So quickly, we'll wrap up in a few minutes. The early studies were all done in patients with diabetes mellitus. So the 3 landmark studies, EMPA-REG outcome came out in 2015, the very first study, which showed positive effects, cardiovascular effects, then followed by CANVAS, then followed by DECLARE-TIMI. So in EMPA-REG, it was the empagliflozin. In CANVAS, it was the canagliflozin. And in DECLARE-TIMI, it was dapagliflozin. So dapagliflozin, the DECLARE-TIMI was a very large study, 17,000 patients, and this was published in 2019. So they all showed a reduction in hospitalization for heart failure. So the point estimate for EMPA-REG was 0.65, so 35% reduction in risk for heart failure. If you look at CANVAS, it's 33%. Here it's 27%. So there is uniformity in all those 3 trials. So this then led to conduction, looking for evidence for use of SGLT2s in patients with heart failure with reduced EF, irrespective of their diabetes status. Okay, so the two landmark trials, DAPA-HF, November 21st, 2019, and Emperor Reduced, which just came out in October of last year. And DAPA-HF, so it is a multi-center randomized double-blind placebo-controlled study, evaluated the effects of dapagliflozin versus placebo in patients with heart failure with reduced EF who were also getting guideline-directed therapy. And 2,373 patients in the DAPA group and 2,371 patients in placebo group, and median follow-up was for about 18 months. So what did they find? The inclusion criteria, I'll skip that for, I'll just show you the inclusion criteria. EF less than 40% or equal to 40%, NYHA class 2 to 4, and the main exclusion criteria are diabetes type 1. Please do not prescribe SGLT2s in diabetes type 1. And the systolic blood pressure of less than 95 and eGFR of less than 30. So not for diabetes mellitus 1, not for GFR less than 30, not for systolic blood pressure less than 95. Those were the patients that were excluded in DAPA. And this is the primary outcome and the results. So the primary outcome is a composite. It has to be either death from cardiovascular cause or hospitalization for heart failure or an urgent visit requiring IV therapy. So you see the patient in the clinic and they are actively decompensated or fluid overloaded. You send them to the ER or you give them IV therapy. So that is what that means. So the red line is the placebo, and the blue line is the DAPA. And this is months since randomization. And this is the cumulative incidence of either any of these three. And so this was statistically significant. And the number needed to treat is fairly low at 21. We saw the same number for sacubitril valsartan for their primary outcome. It's the same number for primary outcome for DAPA. And EMPA, it's again a multi-center randomized double-blind placebo-controlled trial evaluating the effects of empagliflozin versus placebo, and 1,863 in the EMPA group and 1,867 in the placebo group. Median follow-up was 16 months. And one thing about EMPA reduced compared to DAPA. So the same criteria there. Here, they were a lot stricter in their inclusion criteria with regard to EF. Their goal was to get as many people as possible with ejection fractions less than 30%. They were really testing patients who were severely reduced EF. So there was about 72% of their total population was EF less than 30%. And the EF in DAPA was slightly on the higher side. So mostly severely reduced EF in the EMPA group, probably moderate to severe in the DAPA group. And exclusion criteria, once again, then the primary outcome, it was a composite of cardiovascular death or hospitalization for heart failure. The black line is placebo, the dotted line, red line is EMPA, and it was statistically significant, and number needed to treat is 19. So 21 for sacubitril valsartan, 21 for DAPA, and 19 for number needed to treat for empagliflozin. So what do we learn? And these are the side effects on the quickly. The common side effects are on the left side and rare side effects on the right side. And the takeaways from DAPA and EMPA. I literally copied this from 2021 decision pathway. And this is what it says. A subsequent meta-analysis of DAPA-HF and EMPA reduced suggested that the effects of empagliflozin and dapagliflozin on hospitalization for heart failure were consistent, and that these agents reduced all-cause and cardiovascular death. I repeat this. These agents reduced all-cause and cardiovascular death, and improved renal outcomes in patients. So 4 benefits. 1, decrease in hospitalization for heart failure, all-cause mortality, cardiovascular death mortality, mortality from cardiovascular causes, and improved renal function. And lastly, the indications are for SGLT2s now, heart failure with reduced EF of less than 40 or equal to 40, plus or minus diabetes, and that diabetes is type 2, not type 1, NYHA class 2 to 4, and they are used along with guideline-directed medical therapy. Now, ARNI is preferred to ACE or ARB, beta blockers, and MRA. And the starting dose of dapagliflozin and the target dose is 10 milligrams. So you start with 10 milligrams and there is no up titration. I initially started at 5 and then I'm feeling more comfortable. So I'm starting at 10 right now. Empagliflozin, again, the starting and target dose is 10 milligrams daily and no up titration. So what do you watch? Watch for hypotension, volume depletion, because they cause glucosuria and natriuresis. Follow BMP. I usually do a week or 10 days. Look for UTIs and hypoglycemia. So people with, and let's go. When we use them for heart failure, and not everybody has diabetes, that's why I put that down there. So if you're using it for a patient who has no diabetes but heart failure, just watch for hypoglycemia. And these are the contraindications and cautions that are suggested by the 2021 update to the decision pathway. So as you can see in the contraindications, type 1 diabetes mellitus is a contraindication because it puts them at high risk for diabetic ketoacidosis and known hypersensitivity to the drug. Lactating mothers, there is no data, and people who are on dialysis. So don't give it to people on end-stage renal dialysis, end-stage renal disease, or type 1 diabetes. And these were the numbers for the eGFR. In trials with dapagliflozin, they excluded patients with eGFR less than 30 ml per minute. So please think twice before you give it to these people, though it says caution here. And for empagliflozin, the eGFR has to be 20 or higher. And watch for genital infections. And this is once again something we need to pay attention. For people who are on SGLT2s, DAPA or EMPA, and they are going for surgery, they usually recommend stopping it for a day or so before to avoid dehydration and potential risk for DKA. And acute kidney injury, think about it. Urosepsis, think about it. And people who have tenderness, redness, and rash in the genital area, and they are on either DAPA or EMPA, please examine the area and make sure that they don't have cellulitis, because you can easily prevent this Fournier's gangrene. And if they have, it's a very serious complication. Yep.
All right. So we're gonna move to some questions. So feel free to unmute yourself or type in the chat field. Just a reminder, our next talk is next March 18th, and I will be sending out some information how to join that talk as well. So.
Yes, so the next question I have is, if the patient has borderline blood pressure 100 to 110, would we still give it? So I would give it. So those are the patients where I start with 5 milligrams of dapagliflozin or 5 milligrams of empagliflozin and closely monitor those people. The benefits are so many. The benefits are so many. It's not just the heart, it's the vascular endothelium, it's the kidney, it's many, many. I don't know. I'm sure over the next 3-4 years, we'll have data for more benefits. So I would suggest using them.
Another question, ARNI is covered by Medicaid in Washington without prior auth if started in the hospital. Right. It is not being, still not being started. Thoughts on how to move this practice, this change in practice?
I think it's education, 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 Susan. We talked about this a couple of years ago at our heart failure meeting also, how to bring this change. And we put in a button, I think, for the order sets. So residents and hospitalists are the main, and my cardiology colleagues are the main ones who will be using this drug. So it's educating them and letting them know.
Excellent. Okay. Well, thank you very much, everyone, for joining today. And Limbs is asking, let's see. Oh, can we get you in front of our Limbs? Absolutely.
Absolutely. I'll be delighted to share this. And Isadora was here, so she's one of the Limbs doctors here, Dr. Roth.
I know we have several Limbs actually on this call. So again, this is one of 4-part series, and I was able to show you the next few talks. The next one is March 18th, and we'll send out the Zoom links there. We are recording this talk, and we'll record the others, and we will make them available on the Legacy YouTube channel. Once we get those up on the YouTube channel, or get this one up on the YouTube channel, I will send you a link that you can share with your partners and your clinic staff. So thanks for those questions. And we appreciate all of you attending, and hope you have a great rest of your week.
And just my sincere request, let's all learn together. Let's all learn together, and let's all improve outcomes for our heart failure patients. Now, all the 3 drugs I showed today, dapagliflozin, empagliflozin, and sacubitril valsartan, the first thing is decreased hospitalization for heart failure. And we deal with this every single day. Thank you so much.